So we're going to start the next session with talking about ultrasound in abdominal aortic aneurysm diagnosis and treatment. Tish Poe. I've just been given the signal that I forgot we were supposed to do a second drawing. So this is a drawing for a Sockwell makeover. Tish, pull out the next name for the Sockwell makeover. And not looking, she says. Let me put my eyes on. Everybody needs a Carol in their life to keep them on track. She helps me at work, and my daughter helps me at home. So we're going to try this again. Ultrasound in abdominal aortic aneurysm diagnosis and treatment. So Tish is going to start with the first imaging protocols and diagnostic criteria. I've known Tish a long time. She's been to Vic a few times. She's past president of SVU, past secretary for Society of Vascular Ultrasound Foundation. She's starting a whole new role, has started a whole new role working with, being a clinical specialist with Invino. She's moved back to Philadelphia. Please welcome my good friend Tish Pope.
My good friend. You got this working. Good, okay. Well, I want to thank Tina and both the Vic whole community for inviting me back. It's wonderful to be here again, and I am working with a company where I've been immersed in veins and veins and veins, which I'll talk about later today. So it's kind of nice to talk about the aorta, to be honest. So we're going to do that. Okay, so that's my disclosure. And as we look at the abdominal aorta, and I guess I've got the mic on so I can move from the podium, so that's good. These are the kind of the four major areas that you might be asked to look at an aorta. Now there could be others, trauma and infection, other things, but these are the four major areas that we get asked to look at and look for. So when we look at the abdominal aorta, the adult abdominal aorta, so children, of course, are going to be different, and there are differences, some differences between men and women, but in general, the velocity range is going to be between 60 and 100 centimeters per second. That's within normal limits. I have seen higher and I have seen lower, and again, if it falls out of our range of what we call classically normal, then you have to figure out, is that something that's clinically significant, or is it just that person? So the diameter, and these are the points you want to think about. The diameter should taper as you go distally. So the diameter should get smaller as you go distally. I have seen some that don't, and they just stay that way. So as has been said in most of the lectures so far, it's not just what do I see, where does it fall in the criteria, but also what does it mean for that patient and all of that. So now the infrarenal aorta diameter averages 2 centimeters. So that's, again, an average. So then an ectatic, or a not aneurysmal segment, would be between 2 and 3. Again, in general. And look at the size of the aorta going all the way down as you look at this, from the xiphoid process down. So this is a very nice picture of an aorta that has some disease on the, let's see, on your right. And the aorta on the left looks pretty darn normal. So as we look at this, we want to lay out a nice image, and as I say in almost every lecture I do, take color off. Take color off and look at the walls, not just with color on. So when we assess an aneurysm, so we've already established it averages 2 at the distal aorta, that it should taper, and so when an aorta hits about 3 centimeters, that's when you consider it to be a small aneurysm. Greater than 5, and again, intervention being indicated doesn't mean it's mandatory or is going to happen. But we're going to look at the size and then the rate of change over time. Any artery, if you're trying to say, is this artery aneurysmal? Anything that's 1.5 times or 50% more than the normal contiguous segment of it, then you would say that looks like it's aneurysmal. Iliacs, which can be a little harder to judge, and I've asked many interventionalists and many surgeons over the years, because it branches there. So what should it be when you get to the very proximal iliacs, which can be involved in an aneurysm? So greater than 3, and I welcome any physician or anyone here, practitioner or sonographer, to also debate that. I mean, I had to ask a lot of people, what would you call too big at that point? Very important that whatever we think, that we measure it outer wall to outer wall and measure it accurately. Where those cursors go matters. And use both the transverse, the sagittal, and don't forget that there's a coronal plane that you can use, either coming from the side while the patient's lying, or to turn them on their side. And I'll show you some good reasons for that. So as you're searching through the abdomen, and this is a typical, we're looking at, it looks like an aneurysm. Everyone agree? So it looks pretty big. Now let's find the best spot, right? We circle around, we cine loop back, and then we start placing our cursors, outer wall to outer wall, AP and transverse. This looks like a pretty good circular circle to me. So those measurements shouldn't be very different. And one of the things that I have found to be very important in any lab, now does everyone think this was placed just where you would place them? Close, but maybe that the one that goes laterally is a little bit high on that. It's not, but we have edge shadowing too. So when, let's see, I had to figure out where, yeah. So edge shadowing is when around this circle you get dropout, and it can be hard to see that lateral wall. But that doesn't mean you just go up on the circle. And sometimes if you have to get bad data, I would say don't get that data. Just say this is a good AP, I can't really see those lateral walls well, but it looks circular. Which is different from this one that looks like it's literally mouthing something there. I just, the huge amount of laminar thrombus. There could be some plaque, but the B-mode characteristics of this look like laminar thrombus. We're always tempted to measure the residual lumen in all of these, and I think Dr. LeSar is looking down, but I'm going to ask him to look up. So do you need to know the residual lumen on this? Would you want to know the residual lumen? Yes. Yes. So one like this, but do we always, not all physicians, those like, I don't care. So I care, and I'm going to give it to them anyway as far as what the residual lumen is, but it's not, you really want to make sure you get a good outer to outer. Sorry to throw you up there, Chris. Okay, so when we're looking at the aorta, and I know some of you are sonographers, some of you are practitioners, so who's not a sonographer in this audience? So quite a few. So how many of you are asked to do ultrasound at any point? Okay, okay. But when we do this, it's important to know that we're going to approach this, find the aorta, and it may be kind of in the midsection. But how we divide this up when someone on a worksheet says proximal, mid, and distal, right? I like landmarks. I like people to have, what do you call proximal, Tina? Should be what I call proximal. So here we find the aorta, and we can see I've labeled the IVC, the vertebrae, so the spine behind it, and the aorta, nice view. And then we want to move cranially. And if all things are beautiful in that day, you're going to get a beautiful picture like this. Not all of them look like this, right? But this is a very good view of the proximal aorta. So if I said, where are we in a lab going to call proximal? let's say at the level of the celiac. Maybe it's above the celiac, that you have to go past the celiac. But the most important thing is that everybody agrees. Sometimes you can't get above the celiac. So, but that we say not just proximal, mid, and distal, but what are we calling those areas? How will we define them? So if in this particular setting they say mid, when we say mid, it's going to be at the level of the renals. Okay, that at least gives me a landmark where I'm going to be shooting for the same thing and trying to produce the same type of image as the last person, or as me, repeating myself later and going, oh yeah, I'm going to use my landmarks, not just say I'm relatively proximal and distal. This applies in the carotids and many other places too. At the distal aorta, we're still going to see one solid circle, and this is just before it bifurcates into the two. So for anyone who's not already experienced doing ultrasound, this is how we measure this out. And it's important that you know what's being called what. It's also important to know, and for everyone to do it the same, that you have the head to the left side of the screen or the right side of the patient. And in vascular, we really need to adhere to that as well. I don't think in the aorta or in the carotid we tend to flip things around, but I've seen other parts of the body where that happens more often. So cranial is to the left side of the screen, caudal is to the right. This is the SMA as identified here. It could be the celiac, but this is the SMA, and we would sort that out in this image and label it for you. Now it may seem strange that I put an IVC image in here, but especially for new technologists or people who are new to abdomen, I have seen this mistake, which if you look at this, if you don't follow it all the way up or can't follow it to the right atrium, you're not paying attention to your physical landmarks. I have seen a very pulsatile vein signal being identified as the aorta. It's not, and that is, I still say, whatever I know right now, I know so far, and I've been in this even longer than Brian. I had 42 years this last year as far as how long I've been doing this, so count back and go, geez, a lot of images. So, but do recognize that this could happen. This could happen. Now, someone who's reviewing you should be able to look at the, oops, I'm looking there and I shouldn't, could look at the scale and see whether it is approaching or receding. And it's another one of my soapbox issues that looking at positive and negative on that scale is important. So, and for those who don't do ultrasound, it's for those who do ultrasound to watch that the signal is coming positive or negative the way it should based on what you know. All right, so common iliacs, and again, varies a little bit. This is data that I've seen that's been out there for quite a while. I think it was Pollack and Pellerito's book, and I don't know who else before that. But these are some benchmarks, kind of. And again, anything that is an average or a typical can be atypical in your patient. So we have these measurements, and I don't tend to read to you on this. Look at this, and then also you can get this data and these criteria, and they should be there in your lab for you to look at. So as we come down now into a division of that distal one circle aorta into a division into two circles, you have a very large right common iliac artery and a left iliac artery that is sort of in this range. But again, is it a man, is it a woman? And the main thing we're going to see here is that both of them, one is slightly generous, the other one is significantly generous, but hasn't reached 3 yet. Again, all things looking at, is the aorta really small at the distal end? Compare everything to that patient. So what types of verbiage are you going to use when you describe an aneurysm? You're going to say it's fusiform or saccular is kind of one of the major breakpoints. Are all walls stretching? That's fusiform. Is one wall stretching out and the other ones are remaining nice and tight and in good form? That would be saccular. And is it a true aneurysm, meaning that all of the layers, those 3 layers of the arterial wall, all are stretching, as opposed to a false aneurysm, which is where you have a breakout or a hole in the wall and you do have flow maintained into a contained hematoma or some other structure. So this is a rather older image, and from vascular and transplant specialist days. And it is shows you a nice, again, color B mode, which sort of lights up some of this. We do see shadowing, so we can say that, oopsie, I'm sorry, I'm pressing the wrong button. We can see some shadowing, which is the thing you need to see to say that's calcified. Just because something is brighter echogenic material doesn't mean you can say calcium. It's bright, but if it shadows, we can say calcific. This is a beautiful view of a saccular aneurysm. We see one wall bumped out, and saccular aneurysms behave a little bit differently and are approached maybe a little bit differently, but we want to watch for rate of change. And rate of change that would be significant would be over 0.5 centimeter increase in size at a 6-month point past where you did your last study. So that's considered a rapid growth. So again, just looking at some different examples, looking in transverse. In transverse, I can't make this saccular aneurysm look terribly circular. It still looks kind of egg-shaped or oval because it's not all walls stretching together. Then I would expect the measurements of anterior to posterior and lateral to be different from each other. If I think it looks like a circle and I'm getting 4.2 by 5.7, you know, that's not right. That's not a circle. So something was not measured correctly. Okay, and another one, just again, different examples. This one actually has some plaque on one wall, and again, where you place those cursors, I encourage you, even in a lab that you say, well, we're all experienced, we know what we're doing. It's just measuring the circle. To sometimes at your quality meetings or comparison meetings, pull these images out. Where would you have put your cursors? Where would you have put your cursors? And sometimes you find, especially if you have newer and more experienced people, but even among experienced people, where would I have put my cursor? Especially if there's a lot of plaque, or if there is, as in this case, I hope you can see that here is the aneurysm, and you could measure to the first cursor here. I don't know if I'll hit the mark over here, but I'll try. But the first cursor anterior to posterior, but then there's this layer. Now watch what happens when that layer when that moves. You can see that this is pulsing out. Is the aorta pushing tissue behind it? Or is there a break in the intima and there is another bit of saccular laminar, filled with laminar thrombus? So you might not even see that. I have been the one who's made a mistake in times. Other people have too. So another thing to do is look and know what the last measurement was, but measure it yourself and don't try to just match it. And I'll show you a really good case of that in a moment. And not everything you see in these structures is real. This is ring down from a very bright anterior wall. Oopsie, sorry, I did it again. An anterior wall. And we have these like cones in here. Well, that doesn't look like anything I've ever seen, and it looks like we have a ring down or an artifact from that very near wall and the calcific area. Or the very, it's not even, I'm sorry, not calcific, it is a very dense area, and it's creating a ring down. When you go to Doppler, so we've talked a bit about B mode, and it's very important that you look at it with B mode. With Doppler, even if I can't see the takeoff of the renals or something else, if I'm above low resistance, if I'm cranial to low resistance vessels, then I am going to get a signal that is more like the one that we see in the proximal aorta on your left. Once we get past those low resistance vessels, which would be what? Celiac and renals, but especially those renals. Get past that, if the lower extremity vessels have anywhere near their normal resistance, you're going to see a change in waveform pattern from, in terms of resistance, which means end diastolic and early diastolic flow reversal type patterns. Now here's a distal aorta, and I showed you on this last one, we have one that both of them have flow reversal, they have an upstroke, they both are, one is less resistant than the other. So what do you think about this? Does this look like a normal aortic waveform? And you don't have to answer me because people hate raising their hands. I don't know why, but they do. Anybody think yes? Anybody think no? Want to shout out? Yes. You think it looks normal. This one is one that you need to look carefully at, because here is the more proximal aorta. Now this one can fool you, and you can normalize the upstroke and normalize the resistance pattern, which I am very happy that we more and more are looking at the full waveform. The fact that it's triphasic or biphasic does not say the whole thing. What is abnormal here? Tina, go ahead. What's abnormal?
In the distal.
In the one that is the distal.
You've got a little bit of delayed upstroke.
Delayed upstroke, which isn't really very obvious here. Sometimes your ears will tell you, do not turn the sound off and do an ultrasound and duplex. Please don't. Keep your sound on. You may hear a little bit of a turbulence, which could be anything, tortuosity or nothing or whatever, but this one is absolutely leaning. That leaning over, I always call it the drunken lean like that. It's just slow getting there, and it's leaning to the side. That should tell you go up, go more cranially. In the aneurysm itself, you may see a whole lot of just turbulence, and the velocities are going to be kind of dulled out because now you're in a widening. If you've ever seen like a jet of water in a stream, it hits a widening, it's going to start eddying around to the walls of the stream, and then it's also going to be more turbulent. It's going to get to where there's a lot of different flow directions. Laminar flow goes down a very straightaway with minimal branching. How many places in the body do we have that? Not very many, but that's what laminar flow will do. That's not laminar. Now this is where that coronal view comes into play in a very big way. You have a patient, and I don't know about you here, I bet in Tennessee you have a few abdomens that are a little bigger than usual or bigger than you would like. And if you're standing there trying to push down through that tissue and it's hurting you and it's hurting the patient, your shoulder is screaming, turn them on their side. Turning the patient into a right lateral decubitus and coming at that aorta again, lost 5 centimeters of depth. Okay, turn them on their side. Don't try to power through that big abdomen if there is one, especially if it's a fairly solid. Squishy fat's a whole lot better than hard, solid types of tissues underneath. All right, so what is a stenosis? I just showed you one at the proximal aorta. You can look at just the absolute velocity and say, well, that's way out of the range of the 60 to 100 that we consider in normal range. So 50% reduction, though, would be 100% or doubling, moving from one point and then moving downstream and going from what you call normal to what you call the high velocity, or where you think there's high velocity. If it doubles, you can call it 50% stenosis. 4-to-1 ratios have been used for greater than 75% stenosis in some patients, in some criteria. So know as well, just like, and no fault to Tina, that looked pretty normal. Okay, it was biphasic, but the severity of lesions that are distal to a high-grade stenosis can be really hard to tell and underestimate it, because the body's going to try to reestablish normal flow patterns. So you can have an isolated aortoiliac stenosis that's really significant, and you still may have normal common femoral waveforms, and you still may have normal ABIs. And I could talk ABI a lot longer with that, but I'm not going to do it because time is running out. Okay, this is a very old slide of mine. It comes from about 20 years ago when I was in New River Valley Medical Center, and I saw this huge flow going through the celiac. So I put the probe down, another day, another Doppler, you're just moving along, and there's high flow in the celiac. So my first plan of attack was to get after that celiac, and there was high flow. There was a lot of high flow. And then I opened my eyes and saw that there's no flow in the aorta distally. So you see the red flash? Beyond that it's black. There was nothing. It was an occluded aorta. So as I'm beating up the hole, there's a celiac stenosis. It's that, well, the flow went out the celiac because the aorta's occluded. So luckily I didn't spend too much time looking. But we can also find aortic dissections. So dissection is going to be, again, a pulling away from the wall of part of the wall and having a separate flow channel. Transverse, long, color, take color off too. Take color off and look. And when we see this separation through the walls, then we can say that is a dissection, or appears to be a dissection. And dissections can fall in a type A or a type B. The discriminating line there is, does it go past, does the dissection plane, which will also balloon out part of the wall many times, does it start distal to the left subclavian artery? Is it on the arch, or is it further past the subclavian? You can also see these things, which I used to say in my early years. I'd say, it's a short segment dissection, doctor. And it's like, well, it's probably a plaque dissection, where the plaque has now, which is a living tissue with flow in it, it has dissected part of that plaque wall. Flow has forced itself into that. But, so I corrected my terminology, but I've made all the mistakes. I tell you, in 47, I've made every mistake you can think of. This is one that we didn't make, and this was not my catch initially. It was my wonderful colleague who's not, we don't work together anymore, but Mary, and she was working on a machine, and this patient had gone from lab to lab to lab in different parts of the country as he was moving across country to settle with a son somewhere. So, 3 centimeter aneurysm, stable, never changed. Always been 3, it stays at 3. But you have to open your eyes, because when you look at this, notice that as you look down this, as we get down to this part, there's a big sacky thing over here outside of where the aorta has color in it. And so this one did a whole lot of work on, brought him back into the main lab, and then GE at that time had fusion imaging just starting, so apologies to GE, this is early fusion imaging, it's not as pretty as other things. But watch this. So there's flow in there, and then watch just with the ultrasound. You can see on the B mode that there was an actual break in the wall, and the flow is continuing in this sacky thing as you move down distally. So this was not just a 3 centimeter aneurysm, as you would see if you just measured the B mode. And then, it's early, we said, hey, you guys got that new technology, bring it in here. So we did, and this is the CT lined up with the ultrasound in a fusion kind of way. It was very exciting. It was one of the first times we had done anything like this. And watch the little sacky thing. And I say that because I asked the doctor later, I said, was that a pseudoaneurysm? Was that a saccular aneurysm? And he said, you'll never know because I just covered it with a stent graft, and I don't know, you won't know, have a good night, okay? I love it. All right, so let's talk just a moment, and I have just a few minutes left, about what you would see. So that's aneurysms, and I encourage you to compare notes with colleagues. We get so locked into a room in the dark by ourselves, we need to sometimes compare with what other people are doing. Endografts come in many types. You can have the one, just a one modular type thing, and they have grown from early years where there was just a couple of models out there to you better know what kind of thing was put in there, and it can be multiple. They're very creative now with these. I'm not gonna, this is not an endograft lecture, but know what they did. Was it fenestrated, multi-branched? Is it just a simple bifurcated graft? Simple, right? So what is this? And early on, looking at these things, people weren't familiar with it. It's like, I did this aorta and this weird thing in there. And we're gonna see that in some other things as technology and types of devices develop. You see something, you don't know what it is, ask somebody. So again, compare the size. One was done one year, one was done the next. Look at where they measured and try to measure in the same place. Why do we look at endografts? We don't, if they do an open aortic repair, we're not going to spend a lot of time looking at those unless the patient has some symptoms. But in endografts, we have some major types of leaks, with branch leak being the most common. You can have an attachment site either at the proximal or distal attachment sites. These things have to be fixed into the wall. They're not anastomosis, they're fixed into the wall. And you can have intersegmental between the different modules. Graft permeability is not a big deal anymore, at least nothing that I've heard, but in the early days it was. And again, I'm not going to read this to you. You can pull it up as well, but it's not just 1, 2, 3, and 4 now. And 5 means the sac is expanding. We have no clue where it's coming from or why, okay? But the 1, 2, 3, and 4 have different reasons that we can point to. And then there are subcategories of them. The more you know how to talk the language of the interventionalist or the surgeon, the better. So here is one that just on B mode should make you suspicious. Why? There is not, there's asymmetry of the sac. It looks kind of a little bit oblong, which may happen, but there's also not homogeneity of the tissue inside it, or the thrombus. There's gray, black, white, and then when you look at this, there should be no movement of that endograft. The endograft should be sitting there like a rock. It shouldn't be pulsating like we saw, if I go back and then hit this again, that we see movement of the graft material itself. And again, that isn't normal. Oops, go this way. All right, we see one like this, and the graft is in the middle, the very bright and looking long axis of the graft. There's the sac around it, and this one would be hard to miss. All right, you should not miss this one. There's flow in the sac outside of the graft. Okay, we have another one here where taking, even though I don't see color in this two-dimensional view in the sac outside of the graft, I'm going to take the Doppler and move through there and see if I get anything that is an arterial signal, not noise like what we see here. And another thing to be very aware of, you get mirrored images. If you get a signal in an area that you're not getting color fill, or you may even see a spot of color, that it is a reflected signal from the limb. So if I get something directly under that bright limb, again, that can be an artifact. I'm going to go into the limb and into that thing I think might be the signal that is a leak. And if they look identical, it's not. Or what else could you do? You could change your position. Every branch near the sac, if you see branches, and branch leak is very, very common finding, but there's noise seen on the left-hand screen. That is not an arterial signal. On the other side, we see what looks like a normal arterial waveform. If it's a leak, it's going to do more of the back and forth that you see in the Doppler waveform here, to and fro, and you can even see it in the color. To and fro, to and fro. That's pathognomonic for a leak. Okay? And just a couple more of these. I know I'm a minute over. Apologies. Whoopsie. And it's not moving. Did it move? Oh, it did move. It's just not moving here. Okay. So when we look at this, you're going to see branch leaks fairly commonly, fairly often. And I can't see those anymore. So I'm going to go over here. It seems to be what this type of thing, again, to fro, leak. This one is actually one that is a fabric tear. We knew that going in. One of the docs said, come on over and look at this, and you can get your nice picture of what that is. We have heterogeneous material. Now, if it's homogeneous in the sac, in terms of the echo density, that's good. But if it's a recently placed endograft, it hasn't had time to kind of solidify into echo-dense material. So you will see some differences. And if you see blackened areas like blood flow in the sac, you want to at least sample them. We can see limb dysfunction, and I have given you a little bit of a rundown of these things, what you might see. Know that they've gone in with some rather big instruments, and so you want to look at the insertion site for hematoma, for flaps, or for dissections in the arteries that they've gone through. You may get a fistula. Enlargement is a big thing. You want to watch for that. Where's the endoleak coming from? And so with this, there's, get some signals above the graft attachment site proximally, velocities down it, look for branch leak, look at the attachment sites, look for anything that's expanding around it, and then you want to use settings that are going to pick up low flow, because these are often going to be low flow settings. Okay? And there is a duplex protocol here. I think you have those. I've given the PDFs. You're welcome to share them. And enjoy all your waveforms. So thank you.
We're going to keep moving forward here with the next talk that I'm going to be presenting. Hold, please. Don't forget, at the next break, if you haven't seen the vendors outside the sponsors, there'll be another giveaway. Ha. Okay, so Tish did a very good job talking about diagnostic criteria, what we look for when we're imaging the aorta. I'm going to focus on tips and tricks of how to overcome some of the challenges of imaging in the abdomen. So the biggest thing that a sonographer needs to know when overcoming any challenge in the abdomen or doing anything is be very familiar with the anatomy. I threw some indications in here, but Tish did a good job covering aorta imaging and why we would image that. But you need to be very comfortable with your landmarks, why you're doing the study, and the anatomy. So this is the expectation when we get a patient in for an aorta duplex. We're going to get nice images. The patient's going to be thin. You're going to be in and out. So that's our expectation, right? Well, this is our reality. The reality is the aorta is 15 centimeters deep. You've got intestinal gas when you're imaging in the abdomen, and anything you get that's anywhere near diagnostic, you're going, yay, good for me. So how do you overcome some of those obstacles as a sonographer that you may be faced with? Well, I threw this in there, and I know all you sonographers know this forwards and backwards. You're very familiar with this. So this is the Doppler equation, and this is what rules our world, right? But I put that in there because ultrasound is sonographer dependent. In the hands of a good sonographer, you can get a diagnostic study most of the time, but it hinges on understanding the physics and then use your critical thinking skills to applying that to your ultrasound. You didn't just learn physics in school to pass the test. You actually use that as a sonographer to be able to get good images because it's so dependent on that. So what are some of those limitations? Well, we talked about obesity and depth of vessels. I know Tish touched on that. We live in the biscuit and gravy belt. Everybody is diabetic. Everybody eats biscuits and gravy, and you know, we don't judge that, by the way. We just have to overcome it. And then, of course, abdominal gas in the abdomen. So your acoustic window is midline of the upper abdomen or left flank with the patient supine or right lateral decubitus. So that's how you overcome some of that depth of traveling through so much tissue. That ultrasound sends out a pulse, and it has to travel and then come back to the machine. The more tissue it has to travel through, the more attenuated the signal. So turning the patient on their side, coming in from that flank view or the cubitus view can sometimes give you great images when you weren't able to get them with the patient supine. So overcoming the challenges, you want to use a high-resolution real-time imager. Visit some of our sponsors out in the hallway. We've come a long way since I've not been scanning as far as Tish for 40 years, but even I've seen advances in the technology today that you can get great images where maybe back in the day you might not have gotten such good images. Use the appropriate transducer. You want a bandwidth that can penetrate that depth, so you want to use a broad spectrum convex transducer, low frequencies to penetrate that depth. We use higher frequencies for superficial, those lower frequencies to penetrate and for depth. It helps if you scan these patients in the morning, but I will say that if we limited our aortas and our iliacs to morning time, we would never get all of them scanned. So we do scan iliacs and aortas in the afternoon, and I myself can say that sometimes you schedule them in the morning, you ask the patient to watch what they eat, you ask them to take gas X to kind of limit the gas, but it just doesn't matter. And you can come in the afternoon and one of the providers comes and says, I need to work in this aorta, and it's 3 o'clock in the afternoon, and you're like, okay, I'll see what I can see. You know, you're very enthused. But I will say that sometimes I have gotten the prettiest aorta images in the afternoon better than some I've gotten in the morning. So sometimes it's the luck of the draw, right? But we do try to schedule those in the morning to eliminate some of those challenges. Another important step to getting a good aorta iliac ultrasound is to prep the patient. You want the bed flat, the patient supine, arms and legs adequately supported. Elevate the head of the bed, the patient's comfortable. Brian mentioned this in his talk. The first thing patients want to do when you ask them to lie down is to do this. And that automatically, it tightens everything in the abdomen, so I have them rest their arms by their side. The more relaxed the patient is, the better the scan, because if they're not comfortable, then you're not going to get good images because they're going to be moving all over the bed. So make your patient comfortable, and then if they need to, bend their knees to relax the abdominal wall and decrease that back pain. So we've come a long way, baby. We have modern equipment and automatic image optimization that makes our job easier. So I think on most newer equipment these days, there's an auto scan, or I can't remember what some call it, but it's the magic button where if you hit it, it just automatically optimizes everything. But you're not a good sonographer if you just rely on that. I had a mentor that once told me, he is no longer with us anymore, Terry Needham. He said, he was British, but he said, Tina, you've not done a good ultrasound unless you've touched all the buttons. So I don't care how good the imaging equipment gets and how much it does for us, you still have to optimize your images and touch the buttons. And then in-depth knowledge of the device, the underlying mechanisms, all that is essential to getting good images. Use your technical thinking, so you want to utilize your zoom function. Sometimes that can make those images so that the provider can see those a lot better in order to read your study. But don't over zoom it. I've seen a lot of techs zoom it up so much and they've lost all the landmarks. You need those landmarks, and you don't need to zoom it so much that you lose those landmarks, because those landmarks are important in the interpretation of your study. Decrease your depth. Don't waste all that depth at the bottom of the screen. It will better display those small vessels and facilitate placing your Doppler angle. It will help your frame rate, make your resolution better. So get rid of the depth. It will clean up your image. And you can see those walls better, like Tish was talking about, in order to get good cursor placement and accurate measurements. Decrease the sector width. Again, we're talking about physics and your frame rate and your resolution. Adjust your TGCs. Put your focus where you want the focus to be. Turn off that multi-focus. You don't need all that. It just degrades your frame rate, your image, your resolution. Again, lower depth penetration improves the representation of moving structures. You want your depth to be deeper than the structures of interest. So again, it just talks about the ultrasound sending out that pulse. The further it has to travel, the further it has to come back. So get rid of the depth, it will increase your sweep speed, your frame rate, and give you a better image. And this is just an example of how just narrowing that sector, removing those gas pockets, and cleans up that image. Talked about TGCs already. Put your focus at the area of interest. Don't overgain your image. Don't undergain your image. Hit that sweet spot, and sometimes that involves you moving those TGCs to get that region of interest you're looking at. So I had one of my techs go in a room, and I told her, I said, I need you to get some bad images and the same thing cleaned up. So it was an easy patient, and after she came out, it was Sam. She goes, I had a really hard time getting bad images. So I said, I get it. But because this patient was really thin and easy to scan. But it just goes to show you how that image that's overgained, when you clean it up, using what you know about physics and your understanding of the ultrasound machine, can show you here on that, to your left, you can see it looks like there's a lot of plaque in there. It's ugly, and then after she cleaned up the imaging, then how pretty it looks. And it looks clear, open, and the other image, it looks like it's full of plaque. Again, with a Doppler signal, when you're putting your cursor in there, be sure you're using the appropriate angle, 60 degrees. That's what that Doppler equation is telling us that we had to learn about physics. But use your scale, optimize your spectral waveform, clean it up. You can overgain your spectral Doppler. It look like there's spectral broadening when there's not. It's just that the gain wasn't appropriately set. And also, you can overestimate those velocities. We talked about velocities earlier in relevance to carotid disease, but we grade our level of stenosis based on velocity criteria a lot of times. So making sure we have an appropriate angle is really, really important. Because, let me go back one. You'll see that velocity on that one is 87 centimeters per second, or 88. With the angle corrected, or I think the angle was corrected at 88, and then off just a little bit, it elevated that velocity to 115. While that's probably not a huge difference, we have a standard for normal velocities between 40 and 100 centimeters per second. So if you were going to get a ratio based on that 115, you would call that ratio invalid, because that's technically elevated in an aorta. This patient, I think, was young, and that's why they had higher velocities. Again, Tish talked about how important it is to place your caliper when you're measuring an artery following aneurysmal disease, outer wall to outer wall. Don't just throw that caliper on there and take the image and move on. It puts the provider sometimes in a pickle if one tech just threw them up there and the next tech came behind them and put them appropriately. They're thinking, well, did it increase? Did the aneurysm size increase or did it not? Maybe one tech appropriately measured it and another tech just threw it up there because it was 4 o'clock and they were ready to go home or whatever. So it really matters. It really matters when you're surveilling aneurysms. Again, cleaning the image up. You can see the walls better to appropriately place those calipers. That one image, you've got way too much depth. The other image, depth appropriate. You can enhance the temporal resolution, again, like I said, about focusing your ultrasound beam where you want it to be focused. And then Tish talked a little bit about artifacts, but increasing or decreasing your color scale, your Doppler gain, your overall 2D, all of that is important to get the best image possible. And the reason we want to get that best image is because we want to give that provider all of the information they need to make a good diagnosis and care plan for that patient. I'm not going to belabor these artifacts, but we need to know what the artifacts are, because a lot of times it will cause you to make a wrong interpretation on your study just because you weren't familiar that was a reverb, and that's that what you're imaging is not real, it's reverberation. Or like Tish showed that picture with the ring down, and then of course shadowing. So these are just some examples of different kinds of artifact, but you need to be aware of them, and when they come up, know that that's an artifact, and how to be able to really give a good diagnosis for that patient. So at the end of the day, this is every sonographer's creed. Dear God, please let me have all skinny patients tomorrow. Because if you've done everything you can to optimize that image, at the end of the day, the tissue of the patient is an important factor, influencing the process. So if you don't get a good image, you can always say, blame it on the patient. It was their fault, doc. I couldn't see anything. So this I threw in here because this is my happy place, so I wanted to end with my happy place. For you people who live under a rock, this is Disney. And the fireworks show at Disney, I have to go to Disney at least once every year because that's my happy place. My other happy place is the ultrasound room, but this is also one of my happy places. So I think, do we have... Our next speaker is Dr. Quazzo, and he is going to talk about, after we've taken all these images and given him the ultrasound, he's going to talk about treatment options. Am I correct? Treatment options.
You're correct. Thank you so much, Tina. Really privileged to be here. Started with Vic full-time in September, and it's been truly a pleasure to work here. So we're going to talk about aortic treatment. Thank you. And I have no disclosures. So rupture of an aortic aneurysm is a very high mortality event, and usually it's the first and only clinical manifestation of the presence of the disease. So what's the big deal? Aortic aneurysms are present in about 8% of males that are older than 65. This is the 14th leading cause of death in the United States, and ruptured AAAs causes 5% of sudden deaths in the United States. The 5-year cumulative rupture rate of incidentally diagnosed aneurysms in population-based samples is anywhere from 25 to 40% for aneurysms larger than 5 centimeters. And only about 25 to 50% of the patients actually will survive long enough to get to a hospital. The case fatality rate for ruptured aneurysm is around 50% when emergency surgery is performed. So if you look at the numbers of the 100% patients that have a ruptured aneurysm, only about 25% may reach the hospital, and then 12.5% may reach the OR, and of those, maybe only 70.5% can undergo an endovascular aortic repair. So this is the length of the aorta. The aorta is separated into an ascending portion, an arch, a descending, and a suprarenal and infrarenal. Today we're mainly talking about the infrarenal abdominal aortic aneurysm. This is normal adult aortic diameters, and really these can vary amongst individuals. However, the main important point here is that the aorta is considered aneurysmal, essentially by the same definition of other aneurysmal, which is 1.5 times the diameter of normal vessel. So what causes these aneurysms? They can be the result of several degenerative processes, including atherosclerosis, inflammatory, infectious, genetic, and traumatic conditions. Most aneurysms are due to some sort of medial degeneration and appear to occur sporadically. And like atherosclerosis, the aneurysm pathophysiology includes an inflammatory component. And they carry similar risk factors with occlusive disease: age, tobacco use, hypertension, male sex, and hypercholesterolemia. Inflammation in the aneurysms occurs in both the media and adventitia portions, and results in thinning of the media with disruption of smooth muscle and the elastic tissue. Genetics also play up to a component. 20% of individuals with aortic aneurysms will have a first-degree relative with aortic disease. Other connective tissue disorders like Marfan syndrome or Ehlers-Danlos syndromes also convey a very high risk to aneurysm and rupture. A small percentage of aneurysms are related to infection, and these are called mycotic aneurysms. Bacteria can be, many different types of bacteria can affect it. These aneurysms are usually saccular and can carry a high rupture risk. Now, the shape of aneurysms can be described as fusiform or saccular or an eccentric saccular. And the most important thing about this is that, the eccentric saccular type is likely more prone to a rupture. And so we typically will fix those at a smaller size. Aneurysms are found by having high clinical suspicion, depending on patient risk factors. Thorough routine physical exam. A patient can have unexplained back pain, abdominal pain, or pelvic pain. It can be an incidental finding. Worst of all, it's found by rupture. So what is the risk? If you look in the positive column here of risk, you see a lot of the similar risk factors that we see for peripheral arterial disease. And in the negative column, there are some decreased risk depending on race. So Hispanic, African American, and Asians actually have a lower risk of abdominal aortic aneurysms. The other one that's interesting here is diabetes. Diabetes confers a lower risk, and that's pretty strange because we think it would be in the positive column. And the relationship isn't sure why that is. And some people think it may be because of the medication. The key problem is smoking. If you look in this graph, the gray lines are the patients who have smoked, ever smoker as you get older. The never smokers, the risk is way lower, and so it conveys about a 3 to 5 times risk over a lifetime. Again, who's at the greatest risk is smokers, and it's actually dose dependent. So if you smoke more, your risk actually goes up to about 12%. Males are also give you a significant risk factor, and then positive family history. So essentially, this means that screening of these high-risk individuals can save lives. And so the U.S. Preventive Services Task Force recommends that men between 65 and 75 who have ever smoked should get screened. If we look at the vascular surgery guidelines, They also recommend that men and women who have ever smoked between 65 to 75-year-old should get screened with a one-time ultrasound, and then also first-degree relatives of patients with an aneurysm. The Medicare guidelines are pretty straightforward. Males between 65 and 75 who have smoked, and then also a family history. So clinical presentation can vary. If a patient shows up with unexplained flank pain, that's a pretty much an indication for an urgent or emergent repair, as that is a sign of impending rupture. As the aneurysm stretches, especially in the areas of weak areas, you can get significant pain. On physical exam, you can see a pulsatile abdominal mass. It can be picked up by screening, and an incidental finding on radiography or workup for any other arterial disease. So in terms of working up imaging, we can evaluate aneurysms with x-rays, ultrasound, CT scan, MRI, and angiography. However, the abdominal aortic ultrasound, as we have learned today by two excellent presentations, it's very safe, it's low cost, it has an excellent sensitivity and specificity. And we looked at a randomized trial, pooled analysis of 4 different randomized trials that include over 125,000 men. If you do a one-time ultrasound screening in men greater than 65 who have smoked, you can reduce their AAA-related mortality for out to about 15 years. CT and MRI have a risk of using IV contrast, are more involved, but the interesting note is that about 2/3 of aneurysms are found on incidental findings of these scans. So in terms of my ultrasound contribution to the talk is not great, but you know, it's on aneurysms are not straight up and down in the body. They're usually tortuous and have some sort of twisting. And so when you measure them with CT takes us these horizontal slices straight across and usually will cut the aneurysm at an oblique level. So this will overestimate the size of the aneurysm, whereas when you're scanning it in line with the aneurysm, and so you're getting actually a fairly accurate representation of the diameter. So who gets fixed? If your size is greater than 5 centimeters, asymptomatic, you will be offered a repair. 5 separate trials found that there was no survival benefit in repair for anything less than 5 centimeters with the patient being asymptomatic. Again, mentioned before, saccular aneurysms we will repair because they're increased risk of rupture. And anything rapidly expanding, so that would be greater than 5 millimeters in 6 months or 1 centimeter in a year. The guidelines for medical management prior to elective repair include an antiplatelet agent, a statin, which is key, and then cardiac clearance, and then smoking cessation. And we would like that to be at least 2 weeks prior to the repair. Statin therapy is key. As Dr. LeSar mentioned before, it is likely the anti-inflammatory effect of statins that we get this, survival benefit, significantly improves 1 in 5 year mortalities with preoperative statin and postoperative statin. Looking a little bit at the historical aspect of treatment for abdominal aortic aneurysms, it's really very interesting, and as a field, vascular surgery has really developed because of this pathology. So in 1948, this is a 69-year-old gentleman that showed up to his physician, suffered many years of abdominal pain, and the patient was a pipe smoker, a little bit overweight, and on physical exam had a pulsating mass deep in the center of his aneurysm, of the abdomen. And the doctor was Rudolf Nissen, who was a very famous general surgeon at the time. He performed an exploratory laparotomy on this patient and found a very large aortic aneurysm. And at the time, the only way to treat this was to wrap, essentially a cellophane wrap around the aneurysm in hopes that this would create a fibrotic reaction and prevent rupture. It worked for this gentleman for about 5 more years. And let's see. Oh, yeah. But in 1955, he ultimately succumbed to likely a rupture and really refused treatment at that point, which was fairly interesting. So again, the birth of vascular surgery was really around these years. So in 1952, DuBost replaced an abdominal aortic aneurysm with a homograft, meaning a cadaveric, and I believe it was a thoracic aorta from a 20-year-old female. They had some patency, but the biggest problem was the rejection, the active rejection. They just didn't have the immune modulator medication. And then in '54, Voorhees used a synthetic Vinion end cloth in a dog aorta. But then things really started to explode in 1954. Dr. DeBakey and his group at Baylor began working on various materials for grafts. And he actually collaborated with Thomas Edmond, a Philadelphia textile engineer, and he built this knitting machine to make seamless Dacron grafts of all sizes. It was pretty phenomenal. And they didn't require any approval, and they just put them in people. And actually, famous people, the Duke of Windsor traveled down there in 1965, had a very successful repair of his aneurysm. Another amazing forefather of vascular surgery is a guy named Emmerich Silligy. You can see he lived 99 years old and played a very important role in development of these vascular grafts. He invented one that was a woven Dacron graft. He's one of the founding fathers of the Society of Vascular Surgery and the Journal of Vascular Surgery. He did the first televised open repair of an abdominal aortic aneurysm. And basically, all these things came together because at the same time, heparin was being produced safely. You had the development of antibiotics and reliable angiography. And these kind of all came together during these years for this new technology to be born. This is a scene from 1965 in Dr. Cooley's operating room at the Texas Heart Institute down in Houston. And essentially, these are people from all around the world creating a mob scene in the operating room while he does an open heart surgery with a patient on a heart-lung machine. This is considered the time where all these new technologies were becoming available, and everyone was just flocking to learn it. The open repair of the abdominal aortic aneurysm, this is called the V principle for the exposure of the aorta. As you can see, it's maxillary invasive. Essentially, you move all the intestines and everything out of the way and put in your retractors and get down to the aorta. The repair involves clamping the aorta underneath the renal arteries, clamping the iliac arteries, opening up the sac, removing the thrombus, over-sewing the vessels, the lumbar vessels, and then essentially closing the sac over it. Perioperative mortality in contemporary series anywhere between 1% and 5%. This is a cadaveric graft that we use today that can be used in infected fields. This is a Gore-Tex PTFE graft that we commonly use. Now, from about the 60s to the 80s, this became the kind of gold standard repair for aortic aneurysms. It was maxillary invasive, had major morbidity frequently, moderate rates of death, and there was some issue when a patient was medically or anatomically inoperable. So this led to a new era of abdominal aortic management, and there was a development of a catheter-based technique to duplicate this aortic repair. They avoided major intra-abdominal operation and cross-clamping, and the first case was performed by Dr. Juan Perotti in Buenos Aires. He did it on the president of Argentina. Here is the similarities between the repair. In the open repair, like I said, you open the sac and you sew from the top to the bottom. Blood flows through the graft. In the endovascular repair, you place the endovascular graft within the aorta, and the most important point about this is you want to basically obstruct flow into the aneurysm sac, and the most important aspect of that is making sure that you have an excellent seal at the aortic neck. So in this area here, infarenal, this area is defined as the infarenal neck, and you want an excellent seal there. And we talked about endoleaks before, and you want an excellent seal here, an excellent seal here, and exclude the aneurysm. The first EVAR devices were fairly primitive. They weren't great at creating a seal, but now we have very modern devices that are essentially works of art and work way better, and multiple vendors are producing them, and some of them are here today. The repair prevents rupture. It is minimally invasive. It has a lower 30-day mortality, a lower morbidity, shorter hospital stay, and quicker return to full function. The procedure involves getting access to the bilateral femoral arteries. Usually, now we do it mostly percutaneously. We use intravascular ultrasound to size our infrarenal aortic neck, place the main body after performing an aortogram, and then cannulate the contralateral gate, and then angioplasty the rest. Let's see. It's a little video. Oh, I don't think this worked. Can you play that? There you go. So essentially, the graft opens very nicely like this. Each one of these grafts has instructions for use, IFUs. And most of the IFU is centered around this proximal neck. So you can see the length of the neck has to be at least 10 millimeters. The angulation has to be less than 60. And then you have a range of diameters that you can use in terms of the neck. We size with CT. And here, looking at how, again, looking at the neck, which is very important. Here's the neck width. We want to oversize the graft at the neck width around 10 to 20% to make sure that we have a proper seal. The neck length there, again, is important. You want at least 10 millimeters. And then the infarenal angle. You don't want too great of an angle, as that's going to also cause an endoleak. The other thing that you have to pay attention to is the thrombus burden at the neck or the calcification. As that is increased, you will increase your risk of an endoleak. So the different types of endoleak, we have seen this in the last couple talks. The type 1 endoleak is probably the worst type. It's a leak either at the top or from the bottom. That causes the greatest pressurization of the aneurysm sac and can lead to rupture. Type 2 endoleak is usually from an inflow-outflow vessel from a lumbar or the inferior mesenteric artery. Typically, if we do not see sac growth with that type of endoleak, we will just continue to monitor that. Type 3 is an actual disruption in the parts of the graft. Type 4 is actually a porosity problem and usually is very short-lived. Type 5 endoleak is the most frustrating, where you can't find a leak, but you have sac growth. So here is a aortogram of an aneurysm that has an extremely angulated neck. And what are the things that we could use to prevent endograft here? One of the things we can use is an Aptus endo anchor. These are little anchors that go into the neck. Let's see. It's not working. There we go. And there's a little video here that shows the actual anchors will go through the graft, and then will go through the aortic wall and provide a very secure attachment, just like a suture. So that is kind of from the open aneurysm repair. Another way to avoid endo leaks would be with fenestrated endografts. So if you know you have a very difficult neck or no neck at all, you can plan to do a fenestrated endograph. And so we have a case here that I did recently. This is a 63-year-old male. History of diabetes and hypertension. He was referred to vascular from podiatry due to reduced capillary refill and diminished pedal pulses, and he had complaints of 200-foot claudication. He was a 2-pack-a-day smoker since age 15. He had a right-sided carotid bruit. He was worked up by our excellent nurse practitioners with arterial duplex that revealed a left-sided popliteal aneurysm. Left-sided popliteal aneurysm is associated with an up to 50% risk of having an abdominal aortic aneurysm. And our excellent nurse practitioners realized that and got an aortic duplex that revealed a 5-centimeter fusiform abdominal aortic aneurysm. The CTA, which evaluated it further, shows that there essentially is no neck here. So here's your renal arteries here, and the aneurysm you can see is here. It's very calcified, goes up here, it's very large, and there's no neck. Here's the 3D kind of version of that. This is the sagittal view, so looking at it from the side, you can see the aneurysm actually goes all the way up to our superior mesenteric artery. And then there's this kink here. You know, this kink causes angulation, and my concern is that the graft would not, this would cause a channel, endoleak channel, if we didn't include the celiac artery as well. So we took this patient to our hybrid OR and performed a fenestrated repair. The first thing you do in a fenestrated repair is you place what I call these target stents into basically the vessels that you're going to fenestrate. So this is the superior mesenteric artery that we placed a target stent in. This is the celiac artery, and we had already placed the 2 renal artery stents right here. The next part of this case is the most anxiety producing. Essentially, you bring a covered endograft in here and you deploy it, and you cover up all your visceral arteries and renal arteries. And so now they are all ischemic. And so very quickly, choosing to revascularize our superior mesenteric artery first, we brought a laser catheter here and burned a hole right through this graft. You essentially line up the laser with the stent, burn a hole, balloon it, place another stent back into your endograft. Here, and then we next attack the right renal, the left renal, and then we finally finished up with the celiac artery. We then take another endograft, which is bifurcated, and bring it down all the way into our seal zone in the left common iliac artery, and then into the right common iliac artery, and then you have a finished product. If that's gonna run. Can you play that? Yeah. I'm not sure if that's coming out, but so since the 2000s, the current state of aneurysm surgery in the United States has essentially shown an increase in the number of endovascular cases done for aortic repair and a decrease in open repair. And as this extends out to 10 years past this, the same trend has continued, so much that now we're a little bit concerned about our trainees if they're getting enough training in open abdominal aortic repair. What is the evidence-based treatment now over the last 20 years for abdominal aortic aneurysm? This is a trial that was done in the UK where they looked at Patients with very large abdominal aortic aneurysms, they were assigned to undergo either endovascular repair or open surgical repair. And what they found is that the operative mortality was actually lower with the endovascular repair. And at a median of 6 years, there was actually no significant difference between the groups in total mortality or aneurysm-related mortality. And actually, there was more graft-related complications and reinterventions with endovascular repair. If you look at this graph, you can see the top, the red lines are the endovascular repair. And they first start off with a little bit of a separation in terms of aneurysm-related survival, and then as the years go on, the lines pretty much meet. Again, this is percentage survival without a complication. So in the endovascular repair, as time goes on, your complication and your reintervention rate actually goes up as compared to open repair. So in conclusion, in these randomized trials, EVAR was associated with a significantly lower operative mortality than open surgical repair. However, in terms of total mortality, there was no difference seen in long term. And then EVAR, again, is associated with these increased rates of graft-related complications. There's been a lot of different papers generated about this over the last 20 years, and essentially all of them are kind of seeing the same thing. Let's go back. So 30-day mortality is markedly improved, and that's a big point. That can't be taken for granted because, once those patients are lost, they're lost forever, and we do have better perioperative mortality with EVAR. This benefit will disappear as we go longer out in life. But here's a concerning point is that some of these studies are finding that there's an increased aneurysm-related mortality in the EVAR group after 8 years, and that's attributable to secondary aneurysm sac rupture. And in multiple trials, the reintervention rate for EVAR was much higher. And so the question arises, maybe we should consider open surgery first in patients that are younger and that can tolerate it and that have a longer life expectancy. So the most important thing I think to take home about this, because I don't think EVAR is going away as a tool. It's an excellent tool and the technology gets better and better. I think post-EVAR surveillance becomes a more and more important part of EVAR care. This was a study out of Loyola that looked at following EVAR repairs with duplex only. They looked at over 11,000 patients and they separated them into cohorts by post-surveillance imaging modality. And they saw that the ultrasound only cohort after the first postoperative year had the lowest incidence of reintervention, conversion to open repair, and rupture compared to the CTI, MRI surveillance. And they had better overall survival. And these advantages persisted when they controlled for baseline covariates like initial diameter of the aorta, prior aortic surgery, sac growth, and then presence of an endoleak. So this means that post-EVAR surveillance is a critical part of the overall treatment. And essentially when we discuss treatment with patients for elective repair, some will be willing to assume the upfront risk of open surgery to avoid lifelong surveillance and late consequences associated with endovascular repair, and others will not. Endoleak, a little bit about endoleak treatment. We talked about the Aptus endo anchors that can be used as a treatment for type 1A. Also, graft body, we can extend them out and fenestrate later. For the 1Bs, we can do limb extensions. We can coil the internal iliac arteries, use branch devices, and if all else fails, we can explant the graft with open surgery. For type 2, we can perform coil embolization of the inferior mesenteric artery or the lumbars, or just plain embolize the aneurysm sac. For type 3, which are rare, we can reline the graft with a covered graft. For ruptured AAAs, The risk of rupture increases with a diameter size greater than 5.5. If you're currently smoking, have elevated blood pressure, have a high expansion rate, are female gender or severe COPD, or symptomatic. The 12-month rupture risk, you can see here for 5.5 and above, it's anywhere from 1 to 11%. And it gets fairly high as you go over 7. Why do aneurysms rupture? And it's essentially failure of the aortic wall to bear the load of the blood pressure. It's simple as that. We go back to Laplace's law, which is wall tension is proportional to radius times pressure. As that increases, wall tension increases. There's areas of turbulent flow and areas that have increased thrombus deposition that creates a weakness in the aortic wall. Some think that it's due to wall hypoxia and vascular smooth muscle cell death and inflammatory processes. One of the principles that have increased survival in both open and endovascular treatment is this idea of pre-surgical aortic control. We can place emergently, percutaneously via 12 French sheath an aortic occlusion balloon, blow it up, and increases a patient's perfusion of their heart and their brain. Enter the Roboa device. This is a device that we borrowed or came about because of trauma. It actually came about secondary to military trauma. It was invented by an Air Force vascular surgeon, Colonel Rasmussen, and now it's produced as an ER or even pre-hospital kit. It's a 7 French sheath, so much, much smaller. It is a guide wire free catheter, so you don't have to place a guide wire. You don't even need imaging. You just use bodily landmarks. You mark out where the xiphoid is, and you can kind of measure the length, and that's what you use to place the balloon. It also can be placed safely by a trained provider. It does not need to be a vascular surgeon. My ex-partner in the Navy actually carries this in his backpack when he goes out on special missions. The data on this has shown that it has significantly increased survival time in and around aortic ruptures. Aortic ruptures openly are repaired with a Dacron tube graft. There are significant complications of open repair, which we talked about: renal failure, respiratory failure, MI, colon ischemia, lower extremity ischemia, abdominal compartment syndrome, embolization, and paraplegia. If you look at preoperative variables that can predict mortality, if your age is greater than 76, systolic blood pressure less than 70, creatinine value greater than 2, and a pH less than 7.2, and you have all of those, your risk of survival is very minimal. Again, here's one of the hybrid rooms that now we use for aortic repair, especially in terms of rupture. We can, here's a rupture. You can see the rupture occurring right here. Aortic endograft is placed very nicely, covers the rupture and takes care of it very nicely with minimum morbidity. The perioperative morbidity rates, blood loss, and length of stay for EVAR are lower compared to the open repair. The goal is 90 minutes door to surgery, and you can even get faster with that by putting in one of the aortic occlusion devices. Several studies report decreased mortality for EVAR, and the newer generation devices may allow for better than 90% of ruptured aneurysms to be treated by EVAR. This was a rupture at Park Ridge in 2022. Patient came in with flank pain, was transferred, went immediately to the endovascular suite, and percutaneously endograft was deployed, which contained the rupture. However, the patient succumbed to the injury later that night due to a cardiovascular collapse. This leads me again to my first point. The rupture of an aneurysm is a highly mortality event, first and only clinical manifestation of the presence of the disease. So therefore, ultrasound techs save lives with screening and both surveillance. So he played a huge role in the treatment of this disease. Thank you.
Thank you, Dr. Quazzo. Thank you for putting that last line in there, ultrasound techs save lives. Sometimes we have to be reminded what we do every day, and that's why we do what we do every day, take care of patients. So I'm going to introduce our next speaker is Heather Ridge. She's one of the vascular sonographers at Vic. She has been instrumental in helping to onboard new employees. She's been a long-term tech, I don't know how many years, a long time. But she does great working with students and new hires, and she has a case study she's going to present on a AAA.
Hit the green button. Is this it?
Oh, you passed Heather. I stole her clicker. She's my helper at work and everywhere.
Okay, so the objectives for choosing this case study were the importance of what Tish was saying earlier and Tina, the importance of caliper placement, the importance of a great clinical and physical exam. So this patient presented, it was a 78-year-old male referred to Vascular Institute for carotid stenosis. Patient presented with episodes of dizziness and outside study for moderate to severe carotid disease. At the time of the visit, patient states intermittent back pain. Past medical history, history of hypertension and prediabetes, history of tobacco, 1 pack a day for 30 years, but quit 20 years ago, COPD, and peripheral vascular disease. So the patient came to our lab. So here's some images of the presumed level of the renals of the aorta. Like we said earlier, as sonographers, we have multiple limitations every day. So you can see in this image, those calipers are like inner wall to inner wall. So that gives us a measurement of 4.59 centimeters. And this one, when I measured it post-processing, I was getting almost 5.26, is that what it is? Yeah. So we just have to be really careful as sonographers to even the little things, even caliper placements. Just because that between that first picture and that second picture could be the difference of just like 6 months surveillance versus you're going for an EVAR. So we always have to measure outer wall to outer wall. So the interpretation for this exam, it was very limited. We reported the juxtarenal aorta at 4.59 and the infrarenal aorta measuring 4.8. The bilateral iliac arteries were patent. The patient was sent for a CT showing that the right kidney, you can see there is very reduced in size as compared to how echogenic the left kidney is. And that's the infrarenal aorta. You can still see that left kidney lighting up there. So the CTA was the infrarenal abdominal aortic aneurysm with a maximal AP dimension of 5.7 centimeters and a transverse dimension of 5.4 centimeters with moderate atherosclerotic changes. There was a high-grade stenosis of the celiac and the right renal artery, and the right kidney did remain reduced in size as compared to the left. So the patient came back for the surgeon follow-up, reviewing CT images and ultrasound, and upon physical exam, the patient had a tender abdomen consistent with a symptomatic aneurysm. The plan was for the patient to be scheduled for an endovascular abdominal aortic aneurysm repair and possible renal artery angioplasty and stent. So they were returning to Vic for a renal artery ultrasound in 2 weeks from this here's some of these renal images. Like I said, this one was also limited to belly girth and bowel gas, but you can see here in the mid-segment and parenchymals, you can see the delay to upstroke. So as sonographers, we know that that tells us something's going on more proximal. And then that tech measured the aneurysm at the time of that exam, getting around what we got before that exam. So we got 5.8 by 5.9. So the interpretation for that was the right renal artery was not visualized at the origin or the proximal segments, with tardus parvis waveforms noted distally, consistent with a more proximal stenosis or occlusion. The right kidney appears reduced in size when compared to the left. The right renal artery involvement with the aortic aneurysm could not be ruled out. The AAA measures 5.8 by 5.9. So we did intervention with an endograft. Imaging of the right renal artery showed a critical 95% stenosis, and this was followed by angioplasty and stent placement. 1 week post-op. Patient presents 1 week post-op with a 3-day history of right-sided flank pain. ASG duplex performed with a sac size of 5.7 and no evidence for an endoleak. See those calipers there? We're measuring outer wall to outer wall. Time of that exam, we didn't find anything on duplex ultrasound involving the right renal artery stent. However, the surgeon was concerned that the patient may have an infarct to the kidney. Patient underwent diagnostic angiogram, same date of service, with instant stenosis of the stent. However, it showed adequate flow to the right kidney. Of concern, the residual aneurysm sac measures 5.7 centimeters, this being almost a centimeter in size from the pre-op ultrasound. We must think about a possibility of an inflammatory or mycotic aneurysm, which is pretty severe when we think about it, like just following her measurements to the measurements now, we're thinking about an inflammatory process off of caliper placement. So repeat CTA demonstrated a widely patent endograph with no endoleak. Post-treatment monitoring, patient is scheduled to come back to our office for ASG duplex exam in 6 months. The key learnings for this case study were that ASG measurements are very tech dependent, and we must be careful with caliper placement and making sure to get the sac as round as you can. The reality is ultrasound has limitations every day. However, we must do our best with the information that we can see. Renal arteries are also very important for pre and post endograft placement. And a good clinical and physical exam can lead to a great outcome for our patients. Because I really loved the fact that the patient came for carotid stenosis and we're fixing an aneurysm. So, thank you. This is my baby.